Right, I'm going to get started while everything else happens now in the background. So, welcome. So today we are talking about eating disorders and autism, and we are really grateful for the people who have come to share their knowledge with us, really. We know from when we talk to autistic people how the differences are with absolutely everything that they come across. But we know that there has been a big issue within the eating disorder aspect of how different it can be for autistic people. So this is what we're going to be talking about. So just to let you know that today's session is recorded. I'm hoping that Annette has deleted the one from the other one where it was just a mess. And this will be uploaded to our YouTube website, and Annette will send out the link afterwards. It won't be ready. Our videographer sort of edits it a little bit just to tidy it up. He doesn't change anything that's in it. It's just tidying it. And it'll be sent out, and we will also send out the presentations as well. So please put some questions in the chat. Each person who is speaking will say their bit, and then there'll be a time afterwards for us to ask the questions from the speaker. We may not get through all of them. There may be some questions that they are unable to answer, but we will try our best to get there and get some answers to you afterwards if that is the case. So this is a welcome to our people today. So we have got Millie, who I am definitely there. I just cannot see her on my screen at the moment, but she's here. Yes, I can see her on there. So Millie is from the East London Foundation Trust, so ELFT as we locally know it, and is a specialist eating disorder practitioner. And then we've got Amy, who has kind of been sending the links through, who works for a local charity, Caroline. And she's the acting clinical lead, and she's going to be talking about how they do things differently for their autistic patients. And then we've got Emily Nuttall joining us, who is an autistic lady with personal experience, and she is fantastic. And today she has been asked just to talk about her own experiences, because as you will see later on, we are going to be following up today with a training event by Emily next year, in the early part of next year, where she talks about the work that she does within this field. Fantastic person. So she will be joining us in a little while. So part of our Hear Me See Me work that we do, we hold these webinars for professionals to find out from each other, learning from colleagues about different ways of working. But we also hold focus groups, voice groups alongside this with autistic people across the east of England. And so we held one a little while ago about eating disorders. And one of the ladies who was on there, she now has a very, very busy life. And she's got children who are autistic that she and other needs that she needs to look after and care for. She works, and her partner is also disabled, medically disabled. So she's got to treat him with medication throughout the day. So her life is really, really full. And she said that when she was actually going to an eating disorder unit, and I think at one time she was an inpatient with it, how she managed to get things on a more even keel for her is that she was given a meal plan. And so she's had clinicians telling her about what would be better to eat, giving her ideas what to do, but just talking ideally really about, these are your better food choices, these are your better this, that and the other. But it never worked for her because, as she says in this bit here, she doesn't have the imagination to think what to make out of those foods. So when she was in this place, she was given this meal plan. So it was like, you buy, do, and with that you make this, and there's a recipe showing what to do. And because of her lack of imagination of what to do with those foods, having that was the difference of getting her eating a healthier diet and actually helping her to get back on an even keel. Now that her life has got really busy, she's finding it all really difficult again. So she's just eating some stuff. And she knows it's not a healthy choice. She knows it's not great for her, but she hasn't got the time at the moment to actually go out and get any better support to help her sort things out. But she's also not in a bad place. But it's just how those differences are for somebody who is autistic. That is just one small example, and I'm sure you're going to hear a lot more today. So, Millie, without further ado, I've got you down as going first before Amy.
So, hi everyone, please bear with me. I've only had a few days' notice that I'd be presenting. But my name is Millie and I'm a specialist eating disorder practitioner and nurse with the Bedfordshire and Luton Adult Eating Disorder Service, and I provide the medical monitoring for those with an eating disorder and the highest medical risk. I've been with the service for a little over 3 years, and prior to this I spent about 5 years working on acute mental health wards and have experience working in gastro and A&E, and I also have autistic family members giving me lived experience. And my presentation is going to discuss the adaptations we've made to our service for autistic individuals through our different pathways. Heather, could you pop it on the next slide, please? Thank you. So our service is based in Dunstable. However, we work in a secondary location in Kempston and take patients from Luton and Bedfordshire who have an eating disorder with a moderate to high severity. And we work generally with those that are 18 plus, but we also do some transition work from 17 and a half with CAMS. So eating disorders we currently provide treatment for are anorexia nervosa, bulimia nervosa, other specified feeding and eating disorders, binge eating disorder, and avoidant restrictive food intake disorder. Our service offers psychological therapy, dietetics, occupational therapy, and medical monitoring, which is where I come in. We also provide advice and consultation to other services and work closely with eating disorder units and medical hospitals through our MEAD pathway. MEAD stands for Medical Emergencies and Eating Disorders and is a pathway to ensure a smoother and better supported hospital admission. We're able to refer patients for urgent medical admission or planned admissions, which helps the patient and hospital know why someone is being admitted and what interventions actually required. During the MEAD admission, SEDS remain actively involved and support the individual and the hospital, and we meet with the ward staff consultants, psychiatric liaison service and ward dietitians at least twice a week to review and provide support and advice. We also work in partnership with Caroline, who offer a stepped care pathway to provide support for individuals to prevent them from requiring secondary specialist care. Luckily for me, Amy from Caroline's here, so she's going to speak to you shortly about the diagnostic criteria and ARFID. Thank you. So the adaptations we make for therapy for autistic individuals with an eating disorder. Therapy can be adapted to offer additional sessions to orientate the individual to the room in the building. We keep blinds closed. Unfortunately, we're not able to actually adjust any of the lighting here. We have a good supply of fidget toys that can be brought into session and welcome anyone bringing in their own. And sessions can take a much slower pace, and we can add in extra sessions as needed. We also break down information into smaller chunks and supporting the individual to ensure they understand and are able to process what's been discussed with them. CBT can be more directive than Socratic, so a more concrete approach is used. Integrating more emotional regulation techniques and encouraging more involvement from the family. For example, one of our therapists described a situation where a gentleman with ARFID, learning difficulties, and autism had his mum and PA support him through all of his sessions. Next, perfect, thanks. So the adaptations we make to medical monitoring for autistic individuals with an eating disorder. So brief medical monitoring. This is the monitoring of an individual's physical health status with individuals with an eating disorder that can cause a significant number of risks and changes to their physical health. So my role is to undertake the physical health examination, physical observations such as blood pressure, heart rate, temperature, oxygen saturation, weight, bloods, ECG, and SAS testing. All of the adaptations we discuss with our working together group, which includes service users, including autistic patients. The frequency of our medical monitoring is determined by the medical need and can vary from weekly, fortnightly, monthly, or 2-monthly. How patient views are also incorporated into how we plan this, and we also offer urgent appointments on a Friday morning if we receive an abnormal blood result earlier in the week that we can then review and escalate on Friday to try and prevent a hospital admission. So the adaptations we make, we ensure longer appointments. Usually a medical monitoring appointment with our service will last 30 to 45 minutes. But when we have an autistic individual, we provide hour-long appointments and aim for the time of day to be less traffic time, so that it's going to be less busy for them, less people around, and usually more convenient for them. The extra time allows us more time to go over what we need to speak about in a more relaxed and slower pace, and allow understanding and encouraging the appointments at less traffic times. We also have communication care plans, which are similar to hospital passports. These include topics patients like, they dislike, things that are tricky to talk about, things they might not be comfortable talking about at all, as well as information on their carers and special people and their preferences for equipment to be used. Like, we generally use an in-ear thermometer because it's more accurate, but we have a number of patients that don't actually like this. So we have a non-touch one as well, and then different types of tape and materials that patients don't like. So we've got a good variety. And then preferences on minimal physical contact, such as not taking manual pulses. And I've got a template of this on another slide that I can show you shortly. We also provide images of staff and the premises sent out to patients prior to the initial appointment, including the full details of the appointment and what questions would be asked. And we have a pre-appointment questionnaire. Generally in these appointments, we ask a lot of questions around your physical health, and it can be quite tricky for autistic individuals to actually think about all these questions. So we give the questionnaire beforehand, and then they can fill it out. I can have a glance at it while they're here, and then go through anything that might have changed or any concerns they might have had. And they're able to do this with a carer or a family member beforehand and be able to take their time through it rather than try and think about it all in that hour appointment. We also aim to have the same clinician seeing the patients. There's always the risk of annual leave and sickness, but we only have a very small team, and we ensure that all of our patients have met all of our staff, even if it's just for a few minutes at a time, as long as the patient's comfortable with that. So if I'm seeing a patient that I regularly see, our GP might pop in just to meet them and become familiar with them. Also, our whoever their key worker is from our team will join their other appointments with the psychiatrist or therapist to support with rapport building. We offer in-reach during medical admissions. We also encourage carers to attend the first few appointments. And when the individual is comfortable, we promote independence, attending appointments alone with carers in the waiting area if needed. We also try to avoid hospital admission where possible, providing as much preventable measures as we can by offering additional monitoring as needed. And we know the step down to GP medical monitoring can be quite challenging, and patients often have a difficult time adjusting to the change. So with patients that need a more supportive step down, we'll see them for a bit longer and with a more prolonged step down. So instead of stepping them down when they get to monthly monitoring, we'll step them down after 2 months and ensure they're comfortable with seeing their GP. So this is the first couple of pages of our adapted appointment letter for our initial medical monitoring. The letter includes directions literally from the car park with pictures and the reception where you can get a drink, toilets, And this is only the first 2 pages of it, but the whole document has a step-by-step from car park to the actual treatment room, with pictures of the treatment room as well. And there's also an explanation for everything that we're doing in that appointment, all the questions we'd be asking, why we're asking them, and what interventions we're doing. And such as we check blood pressure sitting and standing, so we have an explanation in there for why we're doing that, which is looking for things like a postural drop. Okay, ready for the next slide? Thank you. So this is our pre-appointment questionnaire. It covers a wide range of symptoms the individual with an eating disorder might experience, and it would be discussed in every appointment, but it can be filled out before coming in. A lot of the questions can seem quite what they wanted to talk about, but when this is brought into the appointment, I have a quick glance over it, can pick up on any points, and might have to ask a little bit further to investigate, but it avoids me having to ask a lot of unnecessary questions. And yeah, and also have a bit about their mood in here as well, because a lot of autistic individuals might find it quite difficult to talk about how they're feeling, and it can be a little bit easier for them. Thank you. And then this is our communication care plan that we use, that's similar to the hospital passport. And so this will have, so this is used with our autistic patients. If another professional needs to see them, such as a doctor, so they can immediately be aware of things that make the individual uncomfortable, their preferences, wishes, things they might not be comfortable with saying to a new person. For example, one of the individuals I support with medical monitoring has sensory needs and doesn't like a regular tourniquet. They don't like the texture and the way it feels on their skin. So this is something we can include in there. And then we have a supply of alternative tourniquets that are a completely different texture. Okay. And at SEDS, we've recently developed our occupational therapy pathway as well. So occupational therapy can support autistic individuals by helping them develop their skills they need for their daily living and enhancing their quality of life. Some of the work that occupational therapies do to achieve this is through sensory integration. Many autistic individuals experience sensory processing differences, which can make everyday sensations overwhelming and underwhelming. Occupational therapists use sensory integration techniques to help individuals manage these sensory inputs more effectively. And then daily living skills. So OTs assist individuals with developing essential daily living skills such as dressing, eating, and personal hygiene. These skills are crucial for independence and self-care. And social skills, OTs work on enhancing social skills, which can be challenging for autistic individuals. This might involve role-playing, social scenarios, teaching appropriate social behaviours, graded exposure, and helping individuals understand social cues. And then personal plans. Each autistic person is so unique, so occupational therapists develop personalised intervention plans tailored to the individual's specific needs and their goals. For example, they may need information providing in an easy read format. These plans are often created in collaboration with families and other professionals. And then the environmental adaptations, OTs may suggest modifications to the individual's environment to make it more suited to their needs. This can include changes at home, school, or work to reduce sensory overload and improve functionality. So occupational therapy is a holistic approach that aims to empower the autistic individual to participate fully in their daily lives and achieve their personal goals. Feedback. So we've received some really positive feedback and ideas from our Working Together group. Some of the feedback that we've acted on is having time to adjust to the setting, taking that extra time to listen, that would to what would help rather than make assumptions, treating the individual as a person, having less focus on the numbers, and having the sensory tools and fidgets available. We have been asked about changes to the environment, such as the lights, but because of the way our lights work, we can't change the brightness of them. However, it's something we're looking into, and in the meantime, we close blinds to ensure a little bit less light in here. Other small reasonable adjustments that we're working on following feedback are getting different gloves for medical procedures. We've had feedback before saying that blue gloves can be quite triggering. They can trigger the memories of episodes of care which have been very traumatic for them. So we're looking at getting a different colour just to try and make patients a little bit more comfortable coming in here. Some of the other feedback we've had for the adaptations made just to medical monitoring are patients and carers report to feel more valued and understood. They report to feel more comfortable and less anxious coming to the appointments. Communication care plans have been supportive when needing a MEAD admission. Professionals from MEAD have also fed back that they found it helpful to have better understanding of the individual and have been able to share with staff in the medical hospitals who are involved in their care. And overall improvement to attendance of medical monitoring. And patients have a better understanding around their physical health and appreciated the extra time given. Okay, and I've got our details on here for our shared medical monitoring inbox. My email, our occupational therapist is happy to answer questions as well, and then there's our team email as well, and happy to answer any questions.
Thank you so much, Millie. So one of the questions is, how do you deal with bloods, please, if the patient is anxious?
So we offer a lot of reassurance. We also have different equipment. We have smaller paediatric needles, and we can have family members in here to support. We operate 2-person clinics. So there's always either myself or a GP and a support worker here. So there's someone that can hold the patient's hand if needed. We have a proper phlebotomy chair that can be laid back, so to try and make them as comfortable as possible. We also have heat packs, cold packs, sensory equipment, anything to try and make them as comfortable as possible. We also try to keep them very involved in their care and understand why we're doing these blood tests, and so that they know exactly what tests we're looking for, why we're doing it, and why we're doing it so frequently. And we try to do it at a time of day that would be more convenient for them. So if it's done later in the day, usually they might have thinking about it and worrying about it throughout the day. If it's done first thing in the morning, it's usually a little bit better. So we just work around to try and find what's better for them.
I'm just going to add in here that we are working on a project called Breaking Barriers to Access Healthcare, and we have developed some videos with the intensive support team for bloods locally, and we'll send the link out when we send out everything from today. But there are some videos on there showing what happens within a blood test, and the team that we recorded with are those who help people who really have got such a phobia of needles, but it does explain what taking bloods are, so they're there if you want to use them, basically. So we'll send the links out. There's lots of other stuff as well. Right, next question. Oh, sorry.
We also have a therapist that can do sessions on needle phobia as well, if it is down to a phobia.
Brilliant. So, do you ever use talking mats to enable people to express their views and experiences?
No, not at the moment, but it's something that we're looking into.
Okay. And Kathy, I think we may have met in the past. Right, going on to the next one. Brilliant service. Should a service user require a specialist mental health bed, i.e. mainstream eating disorder service not eligible, ASD and LD? Do you have local services? We do not have anything like this in Essex for ARFID.
We don't have any specialist beds locally, but we do work with the provider collaborative.
Okay. And then to help with the lighting issues, could you use some plug-in lamps which have the dimming facility on them in the interim?
Our issue is more that the lights are too bright. So I'm not sure if you can see the lights in here. They're all automatic, and we don't actually have light switches, so we can't actually switch any lights off. So the lights can be quite intense.
Yeah, we noticed while you were talking that all the lights went off in the background behind you and then came back on again. And I'm combining the last two, and it also may be something that Amy covers when she talks as well. Sorry if this has been covered. Do you work with ARFIDs? Is the treatment therapy different for ARFID?
This is something Amy's going to be speaking about in her presentation.
Yeah, that's fine. Well, and that is it. So thank you, Millie, so much. Oops. Oh, sorry, one more just popped up. Not sure if you mentioned this. I work in the CAM service and often struggle to get autistic young people to have blood pressure measured due to sensory difficulties. So do you do some work around that?
No, it's not something we've actually encountered yet, but we have different blood pressure machines and different monitors. We have the digital and the manual ones, and we'd always be happy to give demonstrations between staff to show patients what actually happens and can trial it in different ways to try and find a way that makes them comfortable.
Thank you. Right, that is it now for you. I'm not going to wait for any more questions to come in. So thank you all for your questions, and thank you so much, Millie. And without further ado, we will move on to Amy, who I think has got your own slides to show. So I will stop sharing. So Amy is from Caroline. I always get it mixed up with the name Caroline. And so over to you.
So I'm Amy, I'm the acting clinical lead at Caroline, and we are a mild to moderate eating disorder charity based in Luton. And today I'm going to be talking to you about treating ARFID, so avoidant and restrictive food intake disorder in autistic people. So for those of you that don't know, ARFID is an eating disorder, and somebody with ARFID will avoid or restrict their overall food intake or types of food that they eat due to either lack of interest in eating or food, due to the sensory characteristics of food, for example, the taste, the texture, the smell of food, or concern about the consequences of eating certain foods, for example, that they may vomit or that they may choke. And it can result in weight loss and can result in nutritional deficiencies. If somebody isn't eating from a lot of food groups, then obviously there is likely going to be nutritional deficiencies. Psychosocial impairment, again, if somebody is restricting lots of different foods, it's then very difficult to eat socially, to eat out, and may result in tube or supplement dependence. But it's not due to lack of availability of food, for example, due to poverty. The weight loss cannot be explained by somebody deliberately trying to change their shape and weight due to shape and weight concerns. Isn't due to another condition, so for example another eating disorder or mental health condition, and isn't due to cultural or religious practices. For example, if somebody doesn't eat pork because they're Muslim. There are lots of overlaps between ARFID and autism. So for example, decreased social circles, as I've mentioned already, in terms of ARFID, having lots of or a lot less opportunities to eat socially, can lead to decreased social circles, and obviously with autism, in terms of the social communication difficulties and being neurodivergent in a neurotypical world, can lead to isolation and feeling like not having that sense of belonging. In terms of rigid thinking styles, this is very common in ARFID due to kind of having safe and unsafe foods, strict rules around what they can and can't eat, and is obviously present within autism as well. In terms of emotional dysregulation, get high levels of anxiety in ARFID when faced with trying unsafe foods, as well as in terms of being autistic, due to things like sensory overload, difficulties with communication. Burnout is often likely for autistic people, so you see a lot of emotional dysregulation at times, as well as sensory sensitivities. So with ARFID, this to do, as I said, with the taste, the texture, the smell of food, and with autism there will also be other sensory difficulties as well. It's really important that we don't, sorry, I'm just getting rid of the chat because that's distracting me. It's really important that we don't forget the effects of being underweight and in starvation mode for those with eating disorders. So you're likely to see a lot of these overlaps if somebody is underweight or if they are not fueling their body So if somebody is underweight, not eating enough, they're more likely to be isolated, so will have decreased social circles. If your body and brain is not getting enough to fuel you, you will have more rigid thinking styles, be more emotionally dysregulated. In terms of the statistics, so there is actually very little research on treating ARFID and even less research on treating autistic people with ARFID. And there is some research carried out with children, that 21% of children in this study presented with ARFID features, and then these ARFID features frequently then developed into adolescence and adulthood. But there are currently no nice guidelines for treating ARFID, although there is some research that family-based therapy for children and adolescents is effective, as well as cognitive behavioural therapy. As a CBT therapist by background, I will be talking today about CBT-AR, so cognitive behavioural therapy for ARFID, as well as talking about the adaptations for autistic clients. So we're going to start by thinking about those adaptations. So really from the beginning, before you've even started treatment, you want to be thinking about how you can adapt treatment for your autistic clients. And throughout, when you see this yellow box, it will be examples of adaptations that can be added in at each stage of treatment. So the first one is having a collaborative approach, and this is important in CBT anyway, but especially when working with autistic clients, making sure that we're very much focusing on the client's goals within treatment, and they very much have a say of what they would like that to look like. You want to already be thinking about sensory difficulties, which I know Millie mentioned earlier, but things like kind of lighting in the room, thinking about is there going to be any background noise or complex noise, as well as thinking about interoceptive awareness, so being aware that some people with autism may have difficulties recognising hunger and fullness cues. In terms of communication, so on the PEACE pathway, which is a very useful resource pathway, they talk about eating disorders for autistic people, and they talk about communication in terms of communication passports. So you're sitting down with your client and working out what is the best way for them to communicate, making sure that that's then used by obviously client and therapist throughout treatment. In terms of emotion regulation, you may need to do a little bit more emotion regulation work with autistic clients, and for some clients that may also require emotion recognition, so that can be difficult at times. With routine, it's often very important for autistic people, so having a set routine as part of treatment, thinking about how we can add in out of session work as part of their routine. For example, if they use daily planners, using that. In terms of rigidity of thoughts, so sometimes, as Millie also mentioned, a directive approach may work better, but for other clients, it may just be that you need to take a little bit longer with cognitive restructuring. In terms of difficulties with change, obviously demands, again, this comes back to collaboration, so making sure that your clients are aware at each stage of treatment, what is going to be happening next, what's going on in the moment. And in terms of pathological demand avoidance, if that's something that your client has difficulties with, it's making sure that there are several options for clients. And lastly, incorporating special interests. So if this is something you can do within treatment, this can really help with engagement and motivation, as well as rapport building. And there's a nice quote here that actually, if you met one person with autism, you've met one person with autism, which I think is really important, that actually, in terms of all of these adaptations, this is going to look different for every client, which is why it's so important to work with them to discuss what adaptations they need. Over to CBT-AR then. So CBT-AR's main treatment goals are to help somebody to achieve a healthy weight if they are underweight, or maintain weight if they're not underweight, to correct any nutritional deficiencies, helping them to eat from each of the basic food groups, and also increasing that comfortability with social eating. And it's very much not trying to change somebody's personality. It's not trying to get people to eat really weird and wonderful foods and become foodies. And it's very much not force feeding. This is very much led by the client in terms of what foods they would like to be adding into their diet. As mentioned in the previous slide, if we look at the yellow box here, collaborative approach from the beginning. This is something we want to be doing, as well as thinking about kind of the room somebody's in, the lighting, background noise, thinking about masking, so making sure clients are aware that if they don't want to be masking and can stop masking, it's a safe space to be doing that. Stimming is welcome in the therapy room, as well as the use of things like fidget toys. That communication passport from the very beginning, creating that. For some clients, that might look like using a lot of visual aids. I have another client who likes to write everything down throughout the week and then bring that to sessions to discuss, because it's easier for him to read it out than it is to just communicate through talking. In terms of routine, so it might be helpful to have the same appointment time and day each week. And when setting out session work, making sure this is built into your client's routine for the week and planning ahead. So I have a client who likes to know what's going to happen next session, so we come up with a plan together as what we're going to do next week, which helps him to process over the week. And of course, this is where the special interests come in as well. Stage 1 of CBT-AR, once we've thought about those adaptations already, we're now going into the psychoeducation of what ARFID actually is, as well as creating a collaborative formulation, which I'll come on to in a moment. Goal setting is really important at this stage. I'm working with autistic clients, and this is very much led by clients, and also helping them to think about small goals rather than overall goals, and always having a plan B. If everything doesn't work the first time, we have another plan of what else we can do, which can help with emotional regulation. Weight restoring is very important at this stage of treatment, and we also bring in planned regular eating, so planning to eat 3 meals and 3 snacks a day to start with, client safe foods, and monitoring this. So this is where we start to think about that interoceptive awareness, their physical sensations, but also really gathering more information about their thoughts, their emotions. And this may be adapted as well. Some clients might want to have a mood rating rather than writing what the emotion is. So again, depending on the client, how they would like to present this. So moving on to the formulation here. So this is the CBT-AR formulation by Thomas and Eddie, created in 2019. Often people with ARFID have a biological predisposition to sensory difficulties. So they may have difficulties with taste and texture, smells of food, because perhaps they are a super taster. So if you're a super taster, you're going to taste the bitterness of vegetables much more than somebody who isn't. They're also likely to have experienced some food-related trauma at some point, for example, being force-fed when they were a child. And this leads to having negative feelings and predictions about the consequences of eating. So fears over eating certain foods, worries that they may be sick or choke from eating certain foods, not be able to eat it, causes high levels of anxiety. Because of this, they're more likely to then restrict their variety and volume of food. The more that they do that, the more nutritionally compromised they'll become, may become underweight and more likely to continue restricting then. And this can actually affect taste buds as well, where they're again going to be more likely to continue restricting. And of course, they'll have limited opportunities for exposure. If they can't eat a wide variety of foods, they're less likely to be social eating, going out to restaurants and having those opportunities to try new foods or feared foods. So in terms of adapting this for autistic clients, I think you can zoom in your screens. Hopefully I will talk through it with you though. Up the top, we've still got the biological predisposition up here. So for this client, we realised she was probably a super taster. She had that sensitivity to tastes, smells, texture of food, as well as associations. And we realised being autistic, she was more sensitive to tastes and textures. She had experienced some food trauma as well, so she was force-fed as a child, and her mum had a lot of associations between foods. For example, that you can't eat kiwis because they're actually ants' nests. And this led her to having very strict rules around what she can and can't eat, and lots of strong beliefs of things she shouldn't be eating, as well as making her own associations and the worry that she would vomit from eating certain foods. In terms of being autistic, we realise she has more inflexible rules, and actually she finds it harder to manage anxiety, as she often does experience meltdowns. So this led to her restricting her overall intake, and she wasn't eating any fruit or vegetables at all because of the associations and the taste and the texture. We also realised, being autistic, she had some difficulties with recognising hunger cues, so she would also forget to eat and have a lack of interest in food if she wasn't feeling hungry. She was most likely nutritionally compromised because she hadn't eaten any fruit and vegetables for a very long time, and she had limited exposure to food. So she wouldn't go to certain restaurants, wouldn't go on holiday, and actually, being autistic, she's less likely to socialise anyway, as she preferred spending time at home. I've also just put on here, again, from the Peace Pathway, and I saw there's somebody in the chat that's here from the Peace Pathway, and this is a collaborative formulation for autistic people who have eating disorders, which can be used for ARFID clients as well. And obviously there's information up the top here that's very autism specific in terms of processing information. It goes into a little bit more detail about core beliefs as well as protective factors. And really, and this is kind of up to you and your client in terms of what formulation will be most appropriate for them. So moving into stage 2 of treatment. So this is where we start to educate clients on those nutritional deficiencies as well as avoidance. And while they're likely avoiding these foods to decrease their anxiety, while this might work in the short term, actually in the long term, every time they're faced with a feared food, their anxiety will actually increase. So this is helping clients to see that when they initially do face these feared foods, that anxiety may increase, but actually that does come down on its own, and next time that anxiety won't be as high. So helping clients to then identify which foods they do want to be trying, and creating a hierarchy of feared foods. So what are the most difficult foods for them to eat, and what causes a little bit of anxiety, but actually they are willing to try, and working up that list. Again, collaboration, you'll see this in every box, really important at this point, and you really start to get a chance to explore their sensory difficulties at this stage of treatment. Stage 3 is the exposure stage. So there's lots of different ways of adding in new foods and feared foods. One of these ways is through the use of senses. So getting familiar with foods by, let's look at what they actually look like, what do they smell like, what do they feel like on your hands before actually tasting them. Fading it in, so having a very small amount of a feared food with a lot of safe foods, and then building on having more of the feared food and less of the safe food. Use of spices, let's make it more tasty. Chaining to a goal. So I had a client who wanted to be able to eat parsnips. So we started off with parsnip puree, then we had parsnip crisps, and then she was able to eat parsnips after that. Switching it up, if you don't like broccoli boiled, let's try it fried instead. And deconstructing. So another example I have is a client who wanted to be able to eat pizza. So we started by just eating the pizza crust on its own, then building layer by layer with tomatoes, cheese, any kind of toppings. Emotional regulation work might be really important at this point of treatment for autistic clients. So something like a sensory box can be really helpful or equivalent, depending on what coping skills they already use. Again, collaboration is there, really important that clients are choosing how they want to be adding in these foods. And again, being aware of those sensory difficulties and interoceptive awareness training here as well. So at this stage, you continue to help your clients to add in these feared foods as kind of out of session work, and doing this in a way, putting it into their routine for doing this. As well as helping to increase social settings that they can eat in as well. So behavioural experiments around eating socially. Another helpful thing at this point might be cognitive restructuring. Again, this is going to be different for every client. For some clients, exposure will be enough, but for others, they do want to work on those beliefs that they have around food. So an example of a client who had strong beliefs that rice looked like maggots. She thought she would be sick if she were to eat rice, she'd be judged. She felt her skin crawling, tense muscles. She felt nauseous when thinking about eating rice. This led to her feeling anxious and disgusted, and she would avoid the foods. So we thought about what we could change in this cycle. So we started off with changing thoughts. So actually she was able to then think about that this is something new she's trying. She's not going to be judged. She's got someone to support her through it, and she's getting closer to her goals. Maybe her mouth is watering because she's excited. And rice is just rice. And this was a catchphrase she used, rice is just rice. We looked up how it was made. And while there was still some anxiety there, she did actually report some excitement of trying this new food. We worked on relaxing her body as her muscles were so tense before, and this actually did allow her to try rice. And by the end of treatment, she was eating rice all the time. And in terms of adaptations here, for autistic clients, you may need a little bit longer working on this area of cognitive restructuring, or kind of a more guided approach if that works better for your client. And again, it depends on your client as to how you want to look into this. So I had another client who actually information gathering was a great way for him to learn and reduce his anxiety. So we looked up everything we could find on mushrooms. What could he learn about mushrooms? What are the different recipes that he could make to include mushrooms in his diet, and kind of how he could do that. We did tap into what his anxiety was around mushrooms as well, but we also thought about the benefits of eating mushrooms in line with his goals, that actually he'd be able to eat more foods. Actually, he might like them. He could go out for dinner more, but also thinking about the nutrients he'd be getting from that as well. So lastly, stage 4, this is the relapse prevention stage. So with your client, you're looking at all of the things that they have changed so far, but also thinking about the future. What might be difficult for them, what might be something that could cause a relapse or a lapse, as well as how they want to continue changing their eating post-treatment. So in terms of lapses, obviously you can never predict everything that might happen, but being as specific as you can with plans of how they can manage those situations. And when adding in new foods after treatment, very much focusing on routine and building this in for clients. So they're very aware of when they will be trying these new foods. But also to be aware that because of difficulties with change, autistic clients might need a little bit more of a build up to the end of treatment. This might mean spacing out sessions a little bit more, spending more time thinking about the ending of treatment. And lastly, I just wanted to finish with some comments from clients we've had at Caroline. And all of these clients were autistic, or they had self-diagnosed. For example, I feel much more confident in myself now. I'm actually excited about trying new foods. I didn't think I would ever get to this point. My life has improved so much, thank you. And after almost 13 years of being unable to eat a large variety of foods, treatment has allowed me to step outside my comfort zone, and I already see improvement after a few weeks. A little bit of time for questions, and there are some references here. And I've seen a lot of people asking for the slides. I will be sending them through to Heather and Annette, so you will get a copy of those. Thank you.
Thank you, Amy. That was insightful. It's very, very interesting. So you mentioned the peace pathway, and that has come in the comments quite a bit. And Emily, thank you so much. Emily, who is our next speaker, has done some work for Peace Pathway. And when she does the talk in February, I'm sure she could spend some time then talking about that. So, other questions? Annette, help me. I'm trying to find the questions in here.
That's okay, Heather. I haven't actually seen any specific.
Look as well.
I'm going to ask one.
There were a few about Peace Pathway, but I can't.
Yeah. So there was one. I know that ARFID is not picky eating, but how do you technically differentiate between them?
Yeah. Very good question, and I think it really comes down to the effect it's having on their life. So if somebody is then very limited socially, that they can't eat around others, they can't eat out, or if they're not eating anything at all from certain food groups and they're likely to be nutritionally compromised, that's when you would know that it is ARFID rather than just picky eating. And ARFID is also something that is likely to continue. You might find children being described as picky eaters, and that's something that doesn't always last, as children are just learning how to kind of move away from their parents and be independent, but somebody with ARFID, that will then continue.
Thank you. Well, thank you so much. And And again, apologies about the late start that's made us go over a little bit from where we started. So thank you. If anybody's got any other questions for Amy, then just please do put them in the chat, and we'll get answers out to you later. So without further ado, we're going to pass over to Emily. So Emily, I can't see you yet. If you could put your camera on and say hello.
Hello, can you hear me and see me?
I can hear you. Yes, I can see you now. Brilliant. Thank you. So Emily joined us to share her own experiences of eating disorders, and I'm not going to say any more than to just pass over to you, Emily, because you can speak a lot better than I can. So do you want to share your screen?
Yeah, just bear with me because this is where I get tested.
Yeah.
Oh, brilliant. Thank you. So yeah, it's lovely to be with you all. I'm so sorry I missed the first bit, but that's life when you work in these areas. So I got asked to come speak to you today because I recently did some training with Heather's team on autism and eating disorders from lived experience and professional experience now as well. And today Heather wanted me to come and speak about my lived experience and the work I do in autism and eating disorders. So I've got lived experience of autism and anorexia, and I now fortunately work in this area and do a lot of speaking and training, which I'll share a bit about. And my job role has quite drastically increased in the last 6 months that I expected, but it's been very exciting, and you'll hear more about this sort of towards the end of my presentation.
Emily, I'm just going to put in, I have said that you will be doing a training thing next year.
Brilliant.
For everybody.
Fantastic. Yep, so Heather's already booking me in for next year. It's a bit scary to think about next year, but here we go. It's not letting me go down on my thing, so bear with me 2 seconds. There we go. So before I start anything that I share with my lived experience, I always ask these really important questions of what do you see when you look at me? So I want you to think about what image you visualise in your minds when you look at an individual who comes into your service that's autistic, maybe autistic, and does have an eating disorder or perhaps has an eating disorder. What differences or similarities do you notice? What first impressions do you think? Do you recognise if they're masking? And would you see if they had autism or neurodivergence or an eating disorder in other life experiences? And have a think about what else you might notice. So the reason I ask this is from my lived experience. I'll go into a bit of background detail now, but I was diagnosed with anorexia in 2008 initially, 3 years of struggling without diagnosis. I then was in CAMS eating disorder treatment in Guernsey, where I live, and I was sent off island twice to 2 eating disorder units. I was then discharged back to Guernsey and referred back to my community eating disorder team. And they said they just threw around the idea that I might have had autism. They didn't really think anything of it. So they had a brief assessment with me and they said, oh yeah, I've got autism. And they didn't really do anything, unfortunately, for the rest of my treatment at CAMS for the next few years. So I just had to kind of sail along. And then I turned 18 and found myself in adult eating disorder services and mental health services, which was an absolutely traumatizing ordeal for me. And in that time, I spent the next 2.5 years in inpatient and day patient treatment. They didn't know I had autism, and the treatment was not adapted, not met to my needs. The environment was horrific, traumatizing, all of these really awful procedures that I look back on that had to save me in those times, but really, really tough. And the thing that stuck out from those professionals before I got my autism diagnosis in my adult treatment was that, oh, you don't look autistic, you don't look like you have autism. So I think that's why I ask these questions and sort of remind people of this, because actually autism presents in so many different ways, and it's important that we bear that in mind and look at that person as they present and see them for who they are and understand that as you understand their autism and their eating disorder together. So a bit about me. I really struggle when I have to think about who I am and what I do, some of my experiences, but it's really important for my journey. So I've always been told I'm someone that's overcome adversity, in the words of my mum, in some pretty tough times in my journey. Removing the masks that I've worn, I've had to overcome a lot of life events of abuse, trauma, family breakdowns, homelessness, disability. So I've actually got a physical disability as well. And I did struggle prior to my anorexia diagnosis. I was struggling with self-harm and depression and anxiety, and then got my autism diagnosis, and then obviously my eating disorder. But they don't define me. I'm still an individual. I'm still Emily. And I'm an expert by experience here in the States of Guernsey, in the Channel Islands. So I work for our Autism and Eating Disorder Service as an expert by experience. So I deliver training to all of our student nurses, all of our doctors, mental health staff, eating disorder teams, all of the general health care services, social care and education. And I also work nationally as well now. So I do lots of work with Maudsley. I'm overseeing the Transitions in Eating Disorders Youth Intervention project with King's College London. So I'm the expert by experience lead for that. I also work with Peace Pathway, Freed, Maudsley, and all of these other charities, exploring autism and eating disorders through EDAC, which is the Eating Disorder and Autism Collaborative. And it's led me to all these opportunities to help research autism and eating disorders, provide support, provide training, and hopefully to empower and equip services from some of my lived experiences and my experiences of now working in this area. So from a lived experience perspective, when we understand anorexia, recovery and anorexia with its interlink with neurodiversity, eating disorders, other challenges and life experiences, part of my treatment, so when I was in treatment, when I got moved to my autism and eating disorder service in 2017, in October 2017, after a 2.5 year inpatient and day patient admission in general or mental health and eating disorder services, one of the key things that was really important to my treatment from the beginning was having to visualize what did anorexia represent in my brain, being neurodivergent and autistic. And what did that look like? Because I struggled to find the words and I couldn't verbalize it very well. And I masked it quite easily. So I was fortunate enough to work with a clinical psychologist and nurse in my eating disorder team. And the image I came up with on the left is the brain and the washing machine. So basically, it's all my thoughts, all my feelings, the emotions, the eating disorder behaviours, the voice, autism overwhelm, all of my feelings and life triggers, all churning in a washing machine. For me, I would then turn to my eating disorder as a way of trying to shut that washing machine up in my head, to try and manage that sensory overwhelm, to try and manage the distress in my mind because I couldn't express it. And it was all jumbled up, all spinning around. And that was really, really overwhelming for me. And in the end, I had to kind of almost pick out my brain out of this washing machine. I had to understand what my thoughts were, what my feelings were, what the behaviours of my eating disorder were, how they interlink. So we did that through CBTE and through some mantra therapy and art and talking therapy. And that was really important because that visual representation helped me to visualise my experience and helped me to start to piece together my journey of what I'd been going through and why I'd turned to an eating disorder and how my autism also overlapped that. The image on the right is the overwhelm bucket. In my personal therapy, we call it the fuck it bucket. So excuse my language, but I don't really use that too much when I speak. But we call it the overwhelm bucket generally. So for me, it's actually, when I'm overwhelmed, I can't always express those emotions. So I will mask and I'll just tell people I'm fine. Something else might have happened in my life that day, or I might have just had a really bad day or been struggling with a meal plan change, a physical change in my recovery, all of these things. So that would add to my overwhelm. In the end, this overwhelm bucket would just become fuller and fuller and fuller. And I would go into what was called a meltdown. And if I wasn't able to deal with that first line of overwhelm in my treatment and things kept building up, I just wouldn't cope. And I'd go into a sensory meltdown and physical and emotional meltdown. And people used to think that I was just having a tantrum, just not getting my own way. But actually, my brain was full of emotions, full of eating disorder thoughts, the voice, the behaviours. And I was dealing with all the life experiences that I was going through at that point. And for me, like the washing machine, I had to understand what caused my overwhelm. What was the triggers for overwhelm? Was it because I was stressed? Was I tired? Was I exhausted? And a resource from Beat that I do some work with now as well, which I'll share more about, is called Blast. So I had to understand if I was bored, if I was lonely, if I was anxious, if I was scared or stressed or tired. And that was really important to understand these techniques of overwhelm, to then break that down and to build skills and strategies to cope. And for me, that was then able to sort of understand how I would set routine and goals to help my recovery and to help my experiences. So as I said, I was officially diagnosed age 12 in August 2008 with anorexia after having an admission to my children's ward. I'd gone in for medical reasons to my cerebral palsy, but my eating disorder was actually playing a big part in that. And I was then assessed by the CAMS eating disorder team and all these other people and got diagnosed. But 3 years prior to that, I struggled, and it was again a way of coping and masking. And I had my initial autism assessment at 13, but nothing really came about it. And that meant I had 4 traumatic CAMS medical inpatient and outpatient treatment support for the further sort of 7 years. And then in October 2017, I got my official diagnosis, age 23, which feels a very long time ago now. And then again, I was diagnosed with high functioning, originally Asperger's, but then high functioning autism came out. And then again, that masking that I spoke about, and now the service that I work for, I've been under, which I've had eating disorder support from, but I'm fortunate enough to have been discharged nearly a year ago. So just working for the service now. So some of the things that helped me and still helps me, and how my autism diagnosis helped me. A really big part of my treatment journey was building routine. So being autistic individuals like myself, we need to know our routine. We need to know where we're going to be at what time, who we're going to be with and at what time. Meal times are really important. So in that routine, I had to build in my breakfast, my snacks, my lunch and my snack, and my dinner and my snack, and know when I was going to have that. That was really, really, really important for me, because I had to have that time to know when those meals were, when my treatment was, what days my therapy sessions were, my reviews were, my medical checks. Because being autistic, if I didn't know that and I was suddenly called in for a meeting or an assessment or some therapy without knowing, I would just become really distressed and overwhelmed. And if something was going to change, things change, unpredictable life events happen to us all. But if no one prepared me for that change, I'd become really distressed, and I'd really struggled to go to those appointments and I wouldn't engage. So having almost what we did for myself was have a general routine of when I'd have my therapy, my reviews, my physical reviews, my different treatments and my MDT meetings. But we would also have a backup plan, so that if X person, so say my psychologist or my dietitian, if they were off sick, if they were on annual leave, I would have a backup consultant psychologist or psychiatrist or dietitian that I would be able to contact and see instead and have those meetings with. And then they would share that information on a shared system, which was really, really important. The consistency, being an eating disorder treatment, the key to recovery is learning those skills to manage what caused the eating disorder in the first place. Being autistic, you need to manage your life, you need to manage routine, you need to manage your structure, and you need to manage all of these things. So having those consistencies is really, really important. And in the lockdown, obviously, that was a massive thing that impacted me and caused me to relapse a couple of times, because things changed. And actually, having that shared system was so important, because if I did have to see a different person in the team, maybe I'd only met once or twice, I would have to share my story again and again, or where I was at, and it would be quite distressing and quite traumatic. So the shared systems is something we built and I inputted with lived experience, and I'm not in any way technical, shape or form, but actually for me, I can log into that system with my hospital number or whichever number they give me. I can update where I'm at, I could update what was happening, and before meetings, clinicians and professionals could see those updates. They would then address them in the session. So we recognise you've shared that you're struggling with, maybe you're changing your meal plan. Maybe a life event had happened and I wasn't dealing with it and I was turning back to the eating disorder. Maybe my autism overwhelm was too high to do anything with treatment and I was struggling to engage and I needed to kind of come down a little bit in my treatment. Having that awareness before going into sessions and then addressing it with me was really important, because I couldn't be put on the spot in traumatic times. And that was really, really important. Another thing was creative and alternative therapies, which I'll share a bit more about shortly. Actually, CBT is a wonderful thing, and mantra was a really wonderful treatment for me. And that's something I'm currently adapting with Jess Griffiths, who used to be the clinical lead for Beat. We're actually learning how to adapt these treatments in a more autistic friendly way, because the treatment works, But being autistic, I couldn't sit with a textbook. I couldn't sit and have a professional talking to me for hours, and I couldn't process things. But if people help me to draw it, write down the processes, draw out that process and break it down into small pieces, that really helped me to understand how that treatment was coming into my, my journey, my thoughts, my feelings, my behaviours with the eating disorder, and how I could process it with my autism and put it together like a jigsaw. The importance of the environment, I know I was in late, unfortunately, but I heard a few things on the last talk. In my training that I deliver, I talk about the blank canvas environment. Actually, coming in with a blank canvas, the 5, 4, 3, 2, 1 technique of the 5 things you can see, the 4 things you can hear, the 3 things you can touch, the 2 things you can smell, and the taste and the deep breath, which we'll learn a bit more about shortly. That grounded me into the environment. That brought me into the environment. And the key things of open questions of what do you need to engage in this environment, what makes you feel safe and what makes you feel connected and what makes you feel grounded. By asking those 4 simple questions or having them written down in advance, that really helped me to come into the environment. And actually, for seeing me as an individual, I'm still Emily. I've still got a diagnosis of autism and an eating disorder, but I'm still a human being. And actually, just seeing that in my treatment and not seeing me as an illness, because unfortunately there were times where I was seen as a number with my weight check, I was seen as a statistic, I was seen as a measurement, and that was really, really distressing. But seeing me as for an individual, yes, you have to have these checks for safety and to support the treatment, but I'm still a person who's struggling with an eating disorder that is an individual that needed support and needed a way forwards. Some of the things that didn't help me was clinical environments. Yes, unfortunately, we can't adapt every single environment to the full extent that I would love it to for autism and eating disorders. In my ideal world, we'd have blank environments for every individual that comes into services so that they can adapt how they need it with the things they want to see, hear, smell, taste and touch. It can be work sometimes. So for me, using fidget toys, having the light switches that dim, again, I don't know the name for that, but that was a name for it that we use. Having a comfortable chair to sit on, having a cushion, having a blanket. That was really important for me, or having something to hold like a teddy in a really distressing therapy session. That grounded me, because if I was going into a clinical environment, I was not going to engage because the lights were noisy, the environment was echoey, and it was really distressing. And obviously the treatment, if my treatment wasn't adapted, I wouldn't engage, and I would be told I was disengaging and not willing to get better, and therefore threatened with discharge on a few occasions. But actually, for me, I was engaging, but my brain couldn't process it in the way they were treating me. And I was so overwhelmed that I just went into shutdown. But once they started to bring in these other skills to adapt my treatment, I engaged. I was able to sit with it, work with it. And I think as well, the changes that I spoke about. And I think, recognising that any changes, and anything that wasn't going to work would cause me more trauma. The more trauma I had, the more I'd go into my eating disorder, the more I'd shut down with my autism. So those were the things that really didn't help me in my treatment, because actually that made me more anxious, that made me more depressed, and that made me turn to my eating disorder more because I couldn't express what was going on. And if I wasn't in the right environment with the right person, I just wouldn't engage. So really considering those needs was important. So as I mentioned, the senses, the blank canvas and open questions. So in the training that I delivered with Tawana and the team next year, and if any of you want to come onto that, you're welcome. But I do a lot more on this, and I do this in my job, thinking of each new person like me as a blank canvas. I mean by that, I'm an individual. I'm coming into an environment that's obviously built for all kinds of individuals, but I'm different to all of those people, and there's nothing wrong with being different. And it's believing in that and embracing that difference. The 5, 4, 3, 2, 1 technique that I spoke about, and toolbox building to lay out the treatment rooms, and the importance, of being creative and adaptable where possible. And I will give some examples of that in a few moments. Another key thing, so as part of my work with the Peace Pathway, is the importance of communication. A lot of my treatment before my autism diagnosis and during my autism diagnosis, I had different cultures, so lots of professionals with different languages, which was really lovely to have those differences, but I couldn't understand them. So I'd misinterpret what they were telling me in treatment. I'd get overwhelmed, I'd get frustrated, and then I couldn't engage back with them. And I would mishear what they were telling me, and I would get really distressed if I didn't understand them. So what was really important there was that actually they wrote what they were telling me. They gave me eye contact. They were slow with their communication, that they didn't rush the process. And actually, body language, sometimes they would use lots of different actions to explain my different ways of thinking and feeling and my treatment and the changes to my treatment, but I would misinterpret that, and that might be something that would then distress me. And as well, it was actually sometimes if I was really struggling and they were just talking a load of information to me without writing it down, I'd really struggle. So actually writing those things down, writing key points down in my treatment was really important. And the holistic approach as well, actually seeing me as a whole person, seeing my needs and bringing that into the communication. And I think as well, I have a communication passport, the Peace Pathway one that I've helped to adapt as part of my job, and the sunflower lanyard that I'm wearing. By wearing that and having a communication passport, on there I can write, this is how I like to communicate. I can see the challenges in my communication. What's the strengths in my communication? What the weaknesses? And what empowers my communication? Those are key things, and I put it out there to professionals. They would see that on my system and on my communication passport, and we would work with that and write underneath, and everybody would then have a copy of that and check in with it every time I would start treatment or have another review, and we would see where I am at and what level I was at that day to communicate. Another thing to think about from my lived experience is the Maslow's hierarchy of needs. I've just done 8 months of level 3 counselling training, which is now finished, thank goodness. Loved it though, but a big key part of that was learning about Maslow's hierarchy, looking at the whole individual, so looking at me as a whole person and each separate part, and then in linking them together. Because actually, as well as my autism and my eating disorder, I had a physical disability. I've had family trauma, family breakdowns. I've experienced abuse, bereavement, all of these life things that we all go through that are really difficult. But actually understanding how I met those hierarchy of needs and what I needed to meet those needs was really important as part of my treatment. And the image on the right and the quote, by being different, we succeed together. So a young person I supported in our eating disorder service, she came up with this quote and then gave me permission to use it. Embrace those differences, because every individual that comes in with autism is different, and it's brilliant and it's empowering. Embracing those differences and bringing that into the treatment and seeing that individual for their differences is so important, because it allows them to be who they are. It allowed me to be Emily, and that was really, really important. And then we think about some creative and alternative therapies to treat autism and eating disorders and how this helped me. Play-based therapy. So I used to do a lot of play-based therapy before my eating disorder diagnosis and before autism, because I couldn't talk properly until I was about 4. So, speech and language therapy. So I had to do all this play-based therapy, but that came into my autism and eating disorder treatment, a bit like role play, but actually using characters to understand what was my eating disorder. So I would choose a character that represented my eating disorder voice, a character that represented my autism, a character that was representing my life experiences and my life trauma. And we would talk about it almost in like a play or drama therapy, and that was how I could express it. Art therapy, for me, drawing my experiences, drawing my feelings. What did it look like? What did it feel like? What was happening in my head? What was that washing machine doing? What was that overwhelmed bucket doing? And actually, bringing that into the CBT model, bringing it into mantra, the CAT therapy and the SSCM therapy, gave a visual image of that treatment and brought that journey together bit by bit with its different components. Music, writing, singing and playing instruments. I play the piano and I play guitar and I write music, and I've been doing that now for the last 10 years nearly, and that's been crucial to my treatment. So actually I write songs about my experience. I play the piano, I play the guitar, we have singing lessons. That words, those lyrics, is my journey and my story, and sometimes that's the way I express things. And we actually have a mentoring scheme in our service where a music school has joined us, and they have volunteers that sign up to do mentoring, and that has been crucial for some people because it shares their story, it shares their experience, and that's their therapy every week. Lego therapy, again, building the experience for me. What was my experience? What were the people in my journey? What did that look like? And what was going on? And dog therapy was another big key one. So therapy dogs are really, really wonderful. And I saw therapy dogs in my medical admissions when I had to be tube fed. I had them in inpatient admissions, and actually a dog could sense what I was going through. The use of fidget toys, the sensory need to feel something for me. I am a fidgeter regardless of autism. In the words of my mum, I just never sit still. I love to fidget. I've always got to have something in my hands or touch something. But holding a fidget toy whilst going through really difficult experiences in my treatment was really important. Mindfulness and yoga and body therapies, because actually being autistic, having a disability and having had trauma, I've never felt able to be in my own body for a long time. Only in the last sort of 3 years, I've been able to accept my body for what it is now, and I'm weight restored. My body is what it is, despite the challenges, and I embrace that. But learning with my autism, I had to learn how to sit with my body. I learned to feel the different changes with my body. I had to understand that my body had to change. I'm growing up, my body changes like anybody, and that's completely okay. But I had to understand that in a social and emotional way. So mindfulness techniques has been crucial to that. And systemic therapies, I mean, forgive me if that's the wrong term. If somebody knows the right name, then please put that in the chat. But somatic and systemic therapies are so important because it connects you to your mind and your body. And being autistic, I would learn how my mind and body should work together, despite my disability and medical challenges I was facing alongside my eating disorder. It was learning how to connect with my body in a safe way and not see it as a threat. Food exposure therapy and using creative techniques. Actually, obviously, ARFID's been spoken about. But being autistic, you struggle with textures and tastes and smells anyway. So actually understanding the food, how it feels, and playing with it. You know, there's a saying of play with your food. Playing with my food, you know, people used to look at me really oddly when I was playing with my food, if I was out, if I was in hospital. But actually having a feel of that food before I would put it in my mouth was so important, because certain textures would just distress me. It might not be the eating disorder voice, it was just my sensory needs. Incorporating those foods into other foods was really important. So for me, I never used to like mushy foods, but if I incorporated it into a food that I liked, they were more manageable. So things like scrambled egg, I never used to be able to eat scrambled egg, but now I can have scrambled egg and things with bacon, like, and things and peppers and stuff like that. That feels okay for me now, but I've had to learn how that feels and those textures and play with those foods with the OTs and the dietitians, and that's, you know, been crucial to my recovery. Communication vision boards. How do I communicate? How do I visualize my experience? And traffic light systems is really important, because if I was at a high level of distress in my treatment and I was going in for a really long day of therapy and assessments and reviews, if I was a red on the traffic light, I wouldn't engage. I'd be too distressed. I'd probably walk out the room and probably walk out the doors of the service, and you wouldn't see me for the day. So understanding when an individual comes into that service, what is your distress level? Then you know what level they're at and how you approach that level of need and work with that need and not judge it. And that was really important for me, because then the professionals would be like, let's just work together where you're at. They reassured me, they grounded me, and had people around me to support me. And actually, you know, my working experience now, which you'll hear more about in a moment, that's been crucial to my alternative ways of engaging, because sharing my story like I do has actually been my healing and my recovery and seen me grow on this journey. It's already been mentioned as well, but masking. Despite my autism diagnosis and before all of that with trauma and my eating disorder, I used to mask with I'm fine. And actually, it's a safety net. It's a way of feeling protected. And it's trying to show that you fit in and that you're okay and that you're some kind of strong person. But having to learn that I'm not always strong and that it's okay to have emotions and feelings as being a human. But actually, my eating disorder was almost a mask. I had to just say to the world, like that eating disorder voice told me, I'm fine. Not admit anything was wrong, because the eating disorder makes you do that. With my autism, I didn't know how I felt because I was too unwell physically to process at one point. I was too emotionally overwhelmed. I couldn't understand my emotions and it just felt too distressing. So I just tell everybody I'm fine. But actually, what I then did in therapy was we got a mask template, which I can share with, you know, when I do training or share with you generally. We used to draw on that mask template. What does I'm fine represent? Is it the fears, the thoughts, the feelings, the behaviours of the eating disorder? Is it the triggers for your eating disorder? Is it some distress that's happening between my sessions or just before coming into a session? Is it distress about the treatment change or something happening? Why am I saying I'm fine? Because actually, understanding that And learning that I don't need to numb myself with an eating disorder was really important. As a saying, I had to learn, I had to feel it to heal it. Being autistic, that's really hard, but I've had to learn that in my own way, and it's terrifying, but it's amazing because that means I don't turn to an eating disorder anymore. I feel my feelings in my way with autism and I process. And actually that mask hid a lot of pain and a lot of trauma that a lot of my family and friends didn't know about, and they really had to understand that because I hid a lot as shame, disappointment, of guilt, fear, not knowing how to express myself with my autism. It was only when all these adaptations and support and the right people came in could I be my real vulnerable self, and that was crucial to my treatment and my recovery. Removing those masks. There's a quote here from an autistic occupational therapist that I absolutely love, and this is so important. So for autistic individuals who have eating disorders such as anorexia, to feel heard, understood and succeed in the world, they need to find their strengths and the people that will help them get to their hopes and dreams. In order to do so, the ability to make and keep friends is a must. Amongst those friends, there must be mentors to show them the way, a supportive environment where they can learn from their challenges and grow on their journey of recovery and feel a sense of belonging in the world as a society needs to create for them. So how has these experiences of my anorexia and autism and other challenges grown me in the work that I now do? So I started my job at the States of Guernsey Autism, Mental Health and Eating Disorder Service nearly 2 years ago, which is quite scary to think. Originally, I was just an expert by experience, doing 0 hours. It then led to me becoming the expert by experience project worker, speaker and trainer for the service to train people in autism and eating disorders. So nurses, doctors, healthcare workers, medical staff that you might come into contact with, GPs, children's services. So I deliver that training for Guernsey to all kinds of people in autism settings. I also do FREED, which is the first rapid early intervention response for eating disorders. So I do that to adapt it in an autistic way. I work with Peace Pathway to adapt treatment. I've co-written 14 books now, and one of those is Survivors of my experiences, and that's been another way of sharing my journey. And that actually as well, I've worked for something called, what's the word I'm looking for? It's an autism and eating disorder project that's called EDAC, which is Eating Disorders Autism Collaborative. We research autism and eating disorders and understand the needs of that and bring it together into practice and what that should look like clinically, personally, professionally, into treatment, and what's being missed, what are the challenges and how we improve that. So I have been part of a pioneering project for new ideas, for new funding, for new strategies, for new skills. I've been supporting transitions in eating disorders youth intervention called TEDdy with King's College London. So I'm the lived experience lead for that, and we're learning how to transition young people into adult services. How do we transition them so that their transition is effective, empowering and encouraging and meets their autistic needs? I work with Peace Pathway, and I work with other charities as well to be able to bring those experiences to life. And train independent services in understanding autism and eating disorders through my business called Motivate the Mind. I've also done my level 2 in counselling. I've just finished my level 3, and next September I will be starting my level 4 therapeutic counselling training, because actually having those professionals is so important and we need them more and more. And for me, I've had to learn about that my experience is unique. Other autistic experiences are unique, but if we bring them together, we learn from each other. So these are all the services that I work with Maudsley as well. But it's bringing about those collaborative voices. It's bringing that lived experience. Lived experience didn't exist in my treatment. Had I had that lived experience mentoring, peer support, like we do now in our service, that would have been an absolute game changer for me, and probably, helped me so much more to be understood and to be heard. So me bringing that into my service now has been life-saving and life-changing for some young people and adults that come into our doors. So that's been a really big part of my work and really, really crucial to what I do. And it's all about making a difference, because everybody has needs, regardless of autism or not autism. Everyone has a voice and they deserve to be heard and deserve to be taken into consideration for treatment. And for me, so growing on this journey, the picture on the left is the butterfly. So for me, my mum described it. I remember being in my worst time in treatment. One doctor said I probably wouldn't have pulled through. And, I physically didn't have the strength to even hear them say that. And my mum put together this picture of a butterfly, of me trying to find my wings again and put all the jigsaw pieces of my journey together again. And that actually, you know, for me, you know, it's described as a roller coaster journey. So for me, my recovery has had all the ups of the roller coasters, and I absolutely hate real life roller coasters. But it's been the ups, which have been absolutely wonderful. Maybe that's been, you know, I've physically weight restored. I've achieved something in therapy. I've achieved a new fear with my meal plan. I've managed to, you know, not rely on my meal plan so much and face my fear foods. I've challenged something else in therapy. I've maybe challenged a new social experience, something about my body that I've finally started to accept. So those have been like the things of going up. The things of going down is unpredictable life events, unpredictable changes, distress, overwhelm, other life stresses that I've not dealt with. The loops in the middle is the overwhelm of being stuck in the same vicious cycle and not knowing how to break that. The importance of being my own compassionate, loving best friend. Being autistic, having an eating disorder, and having trauma and having gone through abuse and disabilities, I had no self-worth. I literally did not have any value, acceptance for myself, and I had to learn how to become my own best friend again. All these other friends, families, colleagues, professionals could say really lovely things to me, but my eating disorder made me believe that I wasn't good enough, and that I was only good enough if I had my eating disorder. The autism made me shut down, the eating disorder made me shut down, and I didn't feel good enough to anybody. But by taking that mask off, by letting these people in bit by bit, as I peeled that mask off a bit more, I could let people in, I could let them see me for who I was. And that helped to grow my journey and bring those people into my treatment, and they grew with me and watched me grow into that butterfly. The importance of self-care and self-compassion, being my own best friend, knowing that it's okay to take a day off and have a rest, and being brave and asking for help. Being autistic, I didn't always know my triggers. I had to learn what my triggers were for my anorexia. What made my triggers worse? What situations? What experiences? I had to write them down. We had them on our system in our service for me. So if I then said I was stressed or overwhelmed or worried about something, and they could see it was a trigger for me, we would check in with that trigger on a scale of 1 to 10 or an emoji to represent what that trigger was and how high that trigger was and how that was impacting my eating disorder and my autism, and then find a way to work to bring those triggers down. And at the reminder of being different, we succeed together. And that self-awareness, you know, I've learned on my experience and my journey and my work and my counselling training that self-awareness is so important. I reflect on that. I do journaling. You know, I see my experiences, and that helps me to continue to grow in what my strengths are, my weaknesses are, my opportunities and my challenges, and bring them together to see myself as an individual. So just before I finish, I just want to finish off with some final thoughts and some general quotes, and then some questions if you've got any. So some final thoughts is to see each individual with autism and eating disorders for more than their illness or struggles, and individualise their care, treatment and support. When you come on, if you are interested in further training from me, we talk about this a lot more in depth with outcome stars, Myers-Briggs, Maslow's hierarchy of needs. So all of these things we incorporate. To never give up hope or belief that someone like myself with autism and eating disorders are not recoverable. We are recoverable, if that's a word, it is in my brain, and we are worthy of care, compassion, treatment, opportunities and support. Despite our diagnosis, we are still worthy of that treatment. I've then got some quotes that I want to finish on. Some was from my mum when I was in my worst point in my eating disorder recovery in inpatient. And there was these 2 quotes that she said to me. It went on my little vision board that I now have and my communication board, that rock bottom is often the solid foundation on which we grow, learn and rebuild our lives and come back stronger. The bravest thing I ever did was continue to live when I wanted to die. I am brave, I am bruised, I am who I'm meant to be. And this final quote was from a clinician that I saw in my autism and eating disorder service, who discharged me a year and a half ago, and that was my discharge from my service as a patient, not as a worker, but they left me with this quote after working with me for 4 years under the service. Look at you challenging that voice, healing those traumas, addressing the difficult challenges, helping us to help you in your own way, and finally speaking bravely and vulnerably. Growth and change gets messy, ugly, painful, but then hope starts to find its way through, and the light shines brightly, because when you're broken and lost on the ground, you will be found. Because perhaps the butterfly is proof that you go through a great deal of darkness, yet become something beautiful. So thank you for listening, and I hope it's been of help. My email is on there and the slides can be shared, but any questions, And just finally, that we are all brave and all bruised, and that by being different, we succeed together. So thank you.
Thank you so much, Emily. Unfortunately, some people had to leave because they had other meetings to go to because we overrun at the beginning, got late start. I'm just looking through, I've got lots of apologies. It's all this, how fantastic you are, and great at sharing this. Thank you for sharing, it's so helpful. You mentioned about too many people involved in the care. Please share your views of the number. How many is too many? Inpatient was, there are a lot of staff members to support. The second question, in inpatient unit, there are so many other patients who might be struggling with similar needs, how it affected you. So how many people is too many in someone's care?
That's a difficult one, because I think it depends on the individual and their needs, but at one point I had about 18 professionals in my care, and I remember it was just the most awful experience because sort of sitting in a room having 18 people stare at you, you feel like you're a criminal, and they just talk to you and just literally don't communicate. But I think MDT meetings are so important, because then you bring people together in those experiences and that treatment, and you bring people together as a whole so that the story doesn't have to be repeated and that everybody's on the same page. But I think it's really reflecting on, or who's key to this person's treatment. Obviously the psychological therapies, the meal therapy, the safety of that individual and that support of that person. So maybe bringing in those key individuals is really important, and then using the shared systems for the rest of those professionals. But I think sort of any more than 10 professionals would be too much. But we try, in our service, we try and make sure there's only about 5 in like big MDT meetings. At a push, we go up to 8, and if it's a really complex case, we go up to 10. But it's individual to every person, and understanding how we bring that in and work with that. But it's seeing where that individual's at and what their needs are, and then working with that, if that helps.
Yeah, thank you. Would you like to stop sharing your screen now, and then I'll ask you? I
didn't realise I was. I'm so
no,
sorry.
I know it's so easy to forget that bit. So the second part of his question, or their question, was, in an inpatient unit, there are so many other patients who might be struggling with similar needs. How did that affect you?
Yeah,
Or did it affect you?
Inpatient was pretty awful for me, because my autism wasn't picked up in my 2.5-year admission in adults. So I was in a very, very noisy mixed environment. So I was actually in a mixed mental health unit at one point, mental health and eating disorders, which was really overwhelming. And that was a real challenge. Noise, sensory, treatment, support, the whole thing. And obviously being in an inpatient unit can be quite a competitive thing for people. And that can be really detrimental to recovery. And that was really distressing. But then on the other hand, I was with 3 other individuals, I remember, who were also autistic and didn't know at the time. And when we all got together, we shared so much in common. And that was almost like my little support in my really dark times. And you can make, I've got some of my best friends now from treatment. And that wouldn't have happened without that experience. I think it has its benefits, but it has its disadvantages as well. Inpatient should be a last resort. So that's why we really look at early intervention, and really look at that early intervention to prevent inpatient, because after having 2.5 years of inpatient, I had to rebuild my life suddenly in the community and think, well, what on earth am I doing? But with the right support in the community and the right intervention, that's kept me 7.5 years out of hospital, and I got told I'd be a revolving door patient for the rest of my life. And having that just shows that if the right support's in place, that can change things. But yeah, inpatient should be a last resort and should only be used in sort of serious circumstances where someone's at risk, and that's why the early intervention is really important.
Yeah, thank you so much. That is the end of the questions that are on there. So thank you. You are fantastic. I'm just going to share my screen as just 2 bits of information for you all. One is, you've got 2 days to do this. There is a public consultation survey out there, if none of you have done that yet. So if you Google it, you'll be able to find it, but the closing date is in 2 days' time. So please get on that. And then just a reminder, and to tell you that Emily is going to be joining us again on the Wednesday, the 12th of February. There's more details and costs that will be coming out on this. when we get it finalised with Emily and get it all sorted. But we'll be sending that out soon. So please do keep that date in your diary. And you've heard Emily talk and how brilliantly Emily explains what that personal side is and how educational that is for anybody working in these services. So when we do send the information out, please do share with other teams as broadly as you can do, because we'd like as many as possible to listen to Emily and to learn more how to be more effective in the work that you're doing. So thank you to all the speakers. Apologies again for the start. We will try and find out for the next time, because this has never happened before. But thank you so much. Thank you, Emily. Thank you, Amy. Millie's already left. But thank you all so much. And we will be sharing all the slides. So until the next time, have a good day. And thank you all.
Thank you.